Hi, my name's Emily, and today I'm going to talk about Group 6's swim lane diagram. I wrote the biography, did part of the diagram, came up with problem solutions and online and video discussions. Also, I'd like to say that Lucy did do a vast majority of the swim lane diagram. Our disease is multiple sclerosis, which is a autoimmune demyelinating disease, and essentially the fatty material around neuronal axons, which carry these electrical signals, starts to sort of break down, and so neurons can't communicate with each other properly, and that causes a range of symptoms, including, sensory and visual disturbances, problems with coordination, cognitive problems, and, things like fatigue. And so about 2.8 million people are living with MS worldwide, and the global stats really also reflect what's going on in the United Kingdom. So the average age of onset is about 30, 33 in the United Kingdom. Vast majority of people are women, and a lot of people suffer with this sort of relapsing condition whereby they're sort of symptomatic, asymptomatic, symptomatic, asymptomatic, and that's kind of where we start off with our patient Suzanne, who's in her 30s, has a son, lives in Cambridge, so part of the NHS, and she, for a time after the birth of her son, she felt very tired, and she had her first attack when she was in her 20s, so she had blurry vision. She didn't think anything of it, but it kept happening, so she went to the optician. He said that she had an inflammation of her optic nerve, optic neuritis, went to the GP, referred to a neurologist, had an MRI, had some blood tests, and 6 months later was diagnosed with multiple sclerosis. And our swim lane diagram really just represents that. So the actors in our patient pathway are grouped within these smaller organisations, and they really do follow the same sort of paradigm. So here's Suzanne, sort of externally, she sort of receives posts, can make phone calls, but within each organisation, you have your healthcare professional and the people that sort of do the online booking administration, so whether that's through IT or through a person, and each organisation has their sort of own data island with their IT infrastructure and their EPR, and so the GP surgery is pretty much the same thing. But the only difference there is that they can communicate with the hospital through NHS digital, and so then you have the hospital made up of several smaller departments, neurology, radiology, and the lab, which again have their own sort of medical staff, with the secondary care EPR, with this translation interface engine, so each of these departments can kind of talk to each other, and then you have the peripheral organisations which are associated with the hospital but aren't necessarily in the main building, I guess. So like the nurse and occupational therapist, etc., etc. So I won't actually get on these today, but just to mention that we did think about it and it's there. This is just a screenshot of our swim lane diagram. It's kind of huge. Have actors at the top, chronological order of events going down. We've coded the events, databases, paper-based documentation, different shapes. The flow of information is denoted by these arrows, so HL7 messages, and acknowledgement is always a dashed line. We have problems in coloured boxes, solutions in coloured speech bubbles, and the level of interoperability denoted by this traffic light system, and actually I think of any input in amber and red. So this would be sort of medium interoperability, so there is data sharing, but there's some loss of some risk of sort of loss or duplication of information, some risk with the patient's delays, and then no interoperability, which would be, huge costs in terms of human interventions, governance, and, massive delays, and, in information risk being lost, etc. So this is the first part of the diagram, and up above you can see there's the actors, patient, the secretary, optician, their data island, the GP secretary, GP data island, which is all I'm going to talk about today. So this is sort of the first part. This is the optician section here. This is the GP, and then I will be talking about the pharmacist, and essentially this part of the diagram is what I put together. So here's Suzanne. She goes to the optician. She makes an appointment using an app, and so all our messages are coded by HR7. So say, for example, SRU would be scheduling information, unsolicited. ADT is admission code. MDM would be sort of medical document management. So whenever someone's sort of editing an EPR, and then you have various other things like the ORM, which is whenever you sort of make an order for a treatment, the GP for a lab test or whatever. So, and there's always an acknowledgement. And again, we've just denoted several areas of potential hazards for poorer interoperability. So she makes her appointment, she goes, and the reception updates her EPR. Yes, she's come. She has an examination, and the optician notices using imaging equipment that, oh yes, she does have optic neuritis. Along the NICE guidelines, it's an urgent GP appointment. He updates her EPR as well, but he also takes the images on a different system, which is the fundoscopy imaging. So that has its own storage. So again, this may, introduce some poor sharing of data between these two systems. He sends an email. It's printed, sent out to the patient, and then she goes to the GP. It's urgent, so she keeps calling the GP, but obviously she can't get an appointment because it's an NHS GP. We've all been there. Eventually she does, and so she's admitted by the secretary, sees the GP. He suspects it's MS, but can't say one way or the other. It suspects a demyelinating disease, updates her electronic patient record, creates a paper prescription, and sends a referral letter to a neurologist. So here he's using all different things. It's the electronic patient record, using SNOMED, but multiple sclerosis actually doesn't have too many codes associated with it, so it's a rather vague code of demyelinating disease, but for some cases, there are lots and lots of codes, but for multiple sclerosis, not so bad, and for optic neuritis, and then he's sort of using a hybrid system here of paper and electronic system, and then sort of using a more up-to-date version of technology using the e-referral with NHS digital. But of course a letter is sent out, and every time a letter is sent out, that's possibility of the letter being lost, and a stop of information flow, and delays to Suzanne's treatment. So if we just think about this a little bit more, the opticians and the GP is very two separate identities, and from reading Guide to Health Informatics, one way you could get away, could improve this complete lack of interoperability is to, with the optician as a data island, is to use sort of health information exchange, like a centralized model where information is sent to this central clinical data repository. So from these sort of remote feeder systems, according to the Guide to Health Informatics. And I guess from my own point of view, that could be if they switched over to more of a FHIR API model, they could have a sort of a cloud-based system where everything is just, from private and the NHS organisations just put on one big electronic patient record, and that would also mean that perhaps the image storage that also could go on there. Another thing to be very concerned about is security. Whenever there's the internet and local systems are sort of interchanging with each other, you need to be firewalled, password protected. You'd have to perhaps think of ways because it's an electronic system in the GP, who could access her information, and ways of sort of having this tiered access, who has full, partial access, and maybe employ these use of these electronic consent systems. For her, the major problem is actually her getting an appointment with the GP in the first place, so you could use a scheduling app with real-time information, with hybrid systems whereby you have this paper prescription. Again, the pharmacist has a different system, so if it's a repeat prescription, may have different information. She may go, the GP may not know about it, may need change in her medication, I don't know. But to sort of test all this, you would need testers to assess a digital integration system if you chose to go completely digital and have more interoperability. But this is a huge expense, and you'd have to sort of test it, user acceptance testing, and it's a huge expense. But actually, I think the NHS has managed it, and now it has the electronic prescription service, so that's good. So if we go further along into the pathway, where we're looking at the neurologist and the radiologist department, then you sort of see several kind of different problems popping up. So this is just the neurologist examining her, and then this is the MRI, which is extremely complicated. But say, for example, different problems could be different systems for documentation in different locations of the patient pathway. This could lead to the patient asking to repeat the same information for a new doctor. So if she's taking that test from the optician along with her, then that's a potential source of she may lose it, he may not understand it, it may not have the same or amount of required information he needs. Again, there's always a security issue. There's always a variation in the documentation and the software. So there's a huge amount of variation in the software when you're using the MRI. You're using different legacy systems. There's a heavy reliance on IT infrastructure. So if this, TIE needs updating, the whole network's down, so nothing can communicate with each other. And also, everyone has to be trained on these things and has to understand, know how to use it. You need to train. That means that you've got to finance all of these things. So potential solutions would be that you could standardize clinical documentation. So you could use this open AIR program, which is electronic health record, which uses these archetypes. It's been developed by clinicians, so it's sort of based on this thing that each things have ubiquitous components, and they have templates. So essentially, even if you did have different documents, they'd essentially have the same amount of information that you could share between sort of softwares and systems. You could train staff, obviously, as I've said, and you could reduce the document-based information exchange by using FHIR, which has an API basis. So different types of software would more easily be able to talk to each other, rather than having all these HL7 messages running around each other in systems not being able to talk to each other. And using this API system, you could use something called a smart platform, which again allows different software to be functionally interoperable. And so then, in that way, you could use digital dashboards, and they could have information feeding into them from different applications. And so really using an API based system really opens up everything and means that all the software, all the systems can talk to one another. And then obviously you still have the same thing about security, so there must be access controlled and password protected, and you have to encrypt everything. But particularly, say for example here with the MRI software, they've got the imaging. If that needs updating, maybe the imaging software wouldn't be read. You have to archive it. Maybe you would use a paper system. You have the reading workstation. The diagnosis would then have to be dictated. That may introduce errors. The Dragon Light software is the Dragon Dictate. And so really, every time that you have a different system, you may say, for example, with the lab results, you know, have this lab management system, and if it's paper, you know, it may not get updated into the EPR. And so, yeah, that's about it really. Thank you very much.